Welcome, everyone. This is a live recording of our podcast, Uncommons, which started virtually in the pandemic, and we've kept going pretty much ever since. And it has, in many ways, it had replaced town halls, and now we're back to doing a version of town halls, but also then publishing it where people then across the country are able to listen to it. And we last week had a live podcast recording with Mo Sharia, the director of police reform at the City of Toronto and community safety and well-being. And this week I think we're all lucky. I'm very happy to have Dr. Jane Philpott join us.
Thank you. Thank you.
Now, Jane, we were colleagues. Now you've led an interesting life, actually, all the way around. Before politics, during politics, post-politics. I hope to ask you about all three stages in different ways. But you have recently written a book, and I want to start there. Health for All. What is the thesis of the book?
Well, let me start, Nate, by saying thank you very much for inviting me to your community and having me on the podcast. Looking forward to our conversation. And thank you also for sharing the news of my book, which is called Health for All, A Doctor's Prescription for a Healthier Canada. And it really is just that. It's the ideas that I have accumulated over a whole range of ways of looking at health and healthcare, and the things that I think we need to do as a country to be able to be healthier. And I break it into sections. So there's the biggest section is about the clinical things we need to do in health systems, but you won't be surprised to know that there are sections in there about social determinants of health and even political determinants of health. And then perhaps a bit unusually, there's a section on spiritual determinants of health, which I think is something that we don't talk enough about. But the biggest thesis of the section that is focused on health systems recognizes the crisis that we have in the country around access to primary care. So about 7 million Canadians who don't have a family doctor or any other access to primary care. And I propose that we actually should be like many other countries in the world that reach close to 100% access to primary care. And they do that by having a primary care team working in every neighborhood, in the same way that we have established a system for public schools where no matter where you go in this country, your children will be assigned to a school, and we know that no one will go without education. We need to make sure that no Canadian goes without access to primary care.
I've seen you mention Dr. Tara Kieran, who happens to be a constituent in Beaches East York and a past guest on Uncommons, where we talked about this in many ways. The idea of ensuring that there is access to primary care has many knock-on positive consequences. Is it a spending question, or is it an allocation of resources question, or both?
It is both, and even more than that. So it is primarily a fact that health is one of the most fundamental human rights, one of the most fundamental obligations of government to provide for their people, to ensure that everyone has the opportunity to attain the highest possible standards of health. And while we have in this country a fantastic system of health insurance, guaranteeing that everyone will have insurance for what we call medically necessary care, if that care is provided in a hospital or if it's provided by a doctor. But we don't actually have a health system when it comes to primary care. There's nobody organizing that when a subdivision grows or a community grows, that when we build the public school, we should also be building the primary care team. And so there are massive gaps in access to care. Here in Ontario, we know that right now about 2.5 million people in Ontario don't have a family doctor. It's estimated that by 2026, there'll be 4 million people in Ontario. That's going to be about a quarter of the people in Ontario. And you know, the reality is it's not just unfair, but it's actually unwise of us to do that, because those are the people who then end up in emergency departments with end-stage cancer that could have been diagnosed months earlier because they had symptoms, but they were afraid to go to emerge, not feeling like they wanted to burden the system, and they wait too long, and then they become not only expensive to treat, which is important, but even more important is that that sometimes it's almost impossible to cure the cancer at that point. So we're making some very foolish decisions as a society by not ensuring that everyone has access to the front door of the health system.
And ensuring that access, you were the federal health minister for a time. It's not to say there isn't a federal leadership role here, but principally this is a provincial question of delivering health teams, for example. The feds can write the check and the provinces are responsible for allocating those dollars in a serious way. And so when we look at health teams and ensuring that there is a health team in every community, that is in part a spending question. We need to spend more in this area on primary care. On the logistics, though, there are many communities and when you look at the lack of access to primary care, overwhelmingly it is lower income neighborhoods or it is northern and more rural areas. And so how do you address those gaps logistically?
So let me first of all start with where you started on that question, and that is to talk about whose responsibility is this. And I argue very strongly that health is a shared jurisdiction. Every order of government actually has a role to play in health. They like to blame one another, the feds say the provinces aren't doing their job, the provinces say the feds aren't giving enough money. You're quite right that provinces are tasked with operationalizing the delivery of the healthcare system, such as it is. But the federal government actually, I think, has much more responsibility than just writing checks. This is serious dollars. It's about $50 billion right now of federal money that goes into the health transfer. It's not responsible to hand over that kind of money without some recognition of how it ought to be spent. And when we've done big successful work in this country, it has involved federal leadership. And so when health insurance came in, it did start in a province, Saskatchewan, under the vision of Tommy Douglas, first installed hospital insurance and then doctor's insurance, and Canada then caught up and implemented it across the country. At the end of the day, we are a country, and the federal government, I think, has a very critical role in saying, not only will we make sure that you have enough resources to be able to deliver health, but we're going to set some standards for what we expect of this money and what Canadians should expect of their healthcare system. And Canadians really need to expect more and certainly deserve more.
Okay, so I was going to ask you about the provincial role insofar as if you were the provincial minister, what would you do? But because you've brought it back to the feds, so if you were still the health minister at the federal level, you negotiated bilateral health accords when you were, and we just went through a renegotiation where there are strings attached insofar as there are priorities laid out, including primary care. They're not tight strings insofar as, if they don't spend it in those areas, there aren't real consequences. Quebec will always have a different accommodation in my experience. But if you were the federal health minister today and you were renegotiating those health accords, there will be more dollars that are part of it. There will be priorities set. How do you ensure that those priorities are realized by provinces?
Well, a few things. First of all, I think we need to rebuild cooperative federalism. We need to see much stronger collaboration between the federal government and provinces on the things that matter so much to Canadians. And there are few things that matter as much as healthcare to Canadians. And I think many Canadians are tired of the squabbling that takes place around this. And we would like to see our health ministers across the country, we would like to see our first ministers across the country sit down in a room together and agree on what's important and how much money should be invested by the federal government and what the expectations should be. Countries that have done well in delivering primary care have often done so through federal legislation. And I provide some examples in the book of countries like Norway that have a Patients' Rights Act that establishes in federal legislation the right to primary care, the expectations that the people of that country should have for how they should access primary care, and what they should do if they don't have it. So there are mechanisms by which I think the federal government could do that, and I actually believe that it's time to modernize our federal health legislation. It's been 40 years since the Canada Health Act was passed. We haven't kept pace with the changing face of healthcare. a lot of healthcare, most healthcare happens not in hospitals but in communities, and much of our healthcare is delivered not by doctors but by teams, including nurse practitioners and nurses and many others on the team. And our legislation doesn't recognize those realities of modern healthcare systems.
At the federal level, we have an interesting example recently where we have on housing Bill of Rights for renters and for buyers. And obviously that is also outside of core federal jurisdiction anyway. It requires provinces to ultimately implement. And so the federal government has used its spending power to say, if you want these dollars, you've got to opt into our Bill of Rights. It sounds like that's kind of what you're imagining. If you want a patient's Bill of Rights in some way, you would say, well, if you want our dollars, you're going to have to do certain things and be more prescriptive. That makes a certain degree of sense, although I can imagine not all provinces will accept it right away. The Saskatchewan example is really interesting in that you saw provincial leadership that then translated ultimately into federal leadership down the road once there was a model in place that we could point to say we're going to expand this and make this national. When you look at family health teams, and by the way, family health teams, so maybe let's start there so everyone understands what you mean by family health team, maybe break it down. And then you said some things about what you might do at the federal level. If you were leading here in Ontario, where it is dire for many people, lack of access to primary care, what do you want to see in the provincial ministry in terms of leadership?
So I think I can answer all of those bits, hopefully all in one. As I said, within a couple of years, we're going to have over 4 million people in Ontario who don't have a family doctor or any other access to primary care. They are left with trying to take care of themselves by themselves or going to the emergency department. Nobody is monitoring their chronic diseases like diabetes and high blood pressure. Nobody is screening them for cancer, providing their children with well baby care, all of those things that you should be able to count on. So what I would propose, and I would propose this in any province, including our own, is let's deal first with those people who are, we use the word unattached, which doesn't sound very personal, but the people that aren't attached to primary care. We need to figure out how many they are, where the needs are the greatest, and start putting these primary care teams in neighborhoods, in the places of most need. And just to describe what that looks like, I tend to use the word primary care home because I like the image of a home. This is a place where you belong, where you are attached to, in a longitudinal relationship with a family doctor or a primary care nurse practitioner that you will see over time for your routine checkups, for your chronic disease management, etc. But if your main provider is not available on any given day, or you have an urgent situation that comes up, you can see someone else on the team. And in fact, it's not always the doctor that you need to see. There are all kinds of things that other providers on the team could do just as well or better. They happen to be less expensive too, so we're actually saving money by sharing the work around and having everybody work to the top of their scope. So that's what I would do. Is I would, I wrote a piece for the Toronto Star a few weeks ago where I proposed, since I wasn't sure whether anybody else was developing a plan, I said, look, we've got 4 million people who aren't going to have access to care. Let's imagine, what if we were to put in 250 new primary care homes across the province? Each of them took responsibility for roughly 16,000 people. Boom, we've taken care of 4 million people just like that. And people say, well, that's going to be really expensive. How can we afford that? The evidence is very, very clear that countries or regions that have strong systems of primary care get better health outcomes at lower costs. And we actually would be paying less in the end, which I think the people in the audience here will understand, because you realize that if you treat things early before they get advanced, not only are you helping to save lives, but you're actually doing it in a less expensive way.
I want to get to the social determinants of health because it's a very similar conversation. But before we get there, when I was crisscrossing the province last year, and it was very obvious that access to primary care, whether it was doctor-led teams or nurse practitioner-led teams, that was the core challenge in Ontario. That was, if I'd been successful, that's the thing that you're screaming about on the healthcare file. It's a lot harder though. It's one thing to say, well, we're going to map out family health teams, and this is what it's going to look like. Making sure that people are graduating medical school and pursuing family medicine is its own challenge, though, in order to populate those family health teams. And one of the challenges isn't just dollars and cents, but that is a challenge. One of the challenges is, which is partly addressed by the family health teams, is the paperwork of small businesses and the bureaucracy and administrative end. I spoke to one woman who teaches and had, I think, 20 some odd residents, and she said none of them are ultimately going into family medicine. And so when you look at the dollars of it and you look at what people want out of medicine when they're getting through med school, how do we ensure that more people are pursuing family medicine?
So you've raised some really fantastic questions. So it's not only how do we make sure that our medical students choose family medicine, and fewer of them are because they see the conditions of work and they don't think it looks very appealing. And then how do we make sure that those who do take a family medicine residency decide to actually set up comprehensive general practice, which is what we need most of all. There are multiple ways that we do that. One of them very much is looking at the conditions of work and which the teams gets at to a large extent. And, what we're hearing from our young physicians and residents is that they want different models of care. They want to work in a salaried system. They want to have the administrative work done as much as possible by other people so that the doctors are freed up to do doctor work. And they want to be able to, have a little bit more control of their lifestyle. That's what developing an actual system, a primary care system in the province can do to be able to create those conditions. There's a whole bunch more than that needs to happen, and we're doing some of that work. I'm really proud of a campus that we've developed at Queen's University. We've established a new campus based in Oshawa with Lakeridge Health, where we've specifically tried to attract students who are committed to becoming family doctors. So you don't get into that campus of medical school unless you say, I'm going to become a family doctor. And then we wrap them around with all of the wonders of family medicine, and we put them into positive experiences right from the start, where they see it not as a frightening, overwhelming, almost impossible career, but they start to see the beauty of family medicine, which is that great joy that family doctors have of getting to know families over a lifetime. And there are many other mechanisms that will be required, but you're quite right that we need to both build the system properly, but the system will be nothing without its human resources, and there needs to be a whole plan.
And if there's someone from Sioux Lookout listening, or someone from Timmins listening, it's one thing to encourage people to get into family medicine. It's another thing to encourage them to practice in more remote locations. Is when you look at the evidence from other jurisdictions, we've tried different supplements and forgiving loans and additional top-up salary. Is there anything else we should be thinking about?
There are many other things we should be thinking about in that regard. Part of it is where we're doing our training. So we know there is now a School of Medicine in Northern Ontario based in Thunder Bay and Sudbury, but we at Queen's have established a partnership with the Winnebago Area Health Authority based in the James Bay Coast region, where we are going to, within a couple of years, be starting to actually be doing training for nurses and doctors and midwives and therapists in community. So we train people of the community who will then stay there over time, which we know that trainees often do. There is, as you know, Nate, a whole other body of work that needs to be done around self-determination in health. Many of those are Indigenous communities, First Nations communities largely, who need to have much more control over health systems, including the development of their own human resources. Excuse me.
We could spend most of, or all of our time on primary care, but the other piece in your book that I wanted to get to is the social determinants of health, because income security has been a big focus of mine. In my own parliamentary advocacy, I was the co-chair of the All-Party Anti-Poverty Caucus alongside Senator Kim Pate. And as part of that work, we very much focused on income supports. So whether it's strengthening the Canada Workers Benefit, most recently under-realized, if we're being honest about it, the Canada Disability Benefit, although an important step forward nonetheless. When you look at the social determinants of health, there are obviously savings and benefits all around down the road. It does come with a fairly significant price tag today if you're realizing the income security that we should be realizing. And so you've lived in politics for at least some time. How do you make the case for dollars today when there's a promise of benefits down the road, when people go, I don't want to pay that today?
Well, you've asked the multi-million-dollar question that is a hard one to answer. I think it comes from a number of places, and you're quite right. You know, when people think of health, they instantly go to health care, and when they think of health care, they tend to think of hospitals, which is really secondary and tertiary care. I think of the health system like a house where we keep focusing on the second and third floor of the house. I argue that we need to build out the first floor, which is primary care, but even more important than that is the foundation of the house, and that's income support, housing, education, all of the things that we know are absolutely essential. I would point you to the work of the amazing Sir Michael Marmot, who was literally wrote the book on social determinants of health, which came out more than 25 years ago. Well, about 25 years ago now. And he worked very closely with Monique Bégin, who is a hero of mine and of most Canadians, a former federal health minister who went on to be part of the commission, WHO Commission on Social Determinants of Health. Michael Marmot just keeps, he's the Energizer Bunny in the UK. He just does not stop fighting for social determinants of health. And he's done some really interesting work with municipalities in the UK who, and has worked at that level to encourage communities to take on being Marmot communities. I'm not sure that he attached the name to them.
I hope not.
But it seems to have caught on in a big way, and it might be something that we should look at doing in Canada, where a real grassroots movement of communities saying we want to ensure that everybody in our neighborhood is properly housed. Everyone in our neighborhood does have the basic necessities that are required through an income, and starts to then demonstrate the data points to prove that those communities actually are healthier and spending less on their health care dollars. So I have you could write volumes of books on social determinants of health. I tried in my book to pick a few that were a bit more unusual that we don't always talk about because it's such an array of topics. Obviously housing, health of newcomers is an issue that I know you're concerned about as well. I look at issues around people living with disabilities who don't have access to the supports they need, early childhood education, early childhood support, all of these things. I don't know what it's going to take to convince governments to make those kind of investments, although, to be fair, the government that you and I were both part of in the 42nd Parliament launched the Canada Child Benefit, and that has probably had more to do with improving the well-being of Canadian children than just about any other government move in the last generation.
Yeah, I think that's right. I take a very probably maybe too direct approach to it in that social determinants of health can mean many different things, but the number one driver is income insecurity. And then you look at the federal level, and obviously the province has a lot to say in terms of the welfare system and ODSP here in Ontario. But at the federal level, you look at, I think of it like you need a basic income, but then not everyone agrees with a basic income. And you have the expert panel out of BC that said no to a basic income when Horgan had put it in place. But what they did say, they basically said no to a basic income, but they kind of said yes when they started drilling in the details, because they said, well, we want a workers' benefit, a supplement for low-income workers, and we want there's got to be a benefit for people with disabilities, and we want to help people who are aging out of care. And when you start to look at the total architecture of it all and you piece it together, you go, okay, well, we've got the Canada Child Benefit for kids and families with kids. We've got OAS and GIS for seniors, which is why as much as we need to continue to help everyone in poverty, seniors have of any demographic of the lowest poverty rate. And then the highest poverty rate is working age Canadians. And within that, it's people with disabilities. And so we, again, under-realize, but we just have to keep focusing on the benefits in place and then improving it where we can, improving it where we can. It feels very slow at times, though.
And there's also an argument to be made, what you're describing is actually a pretty complex system where you're actually administering multiple programs to address multiple groups, and there's obviously an argument to be made to say, can't we just simplify this and administer one program that's actually going to meet the needs of multiple people who are struggling with income
If you were
support.
writing it from the get-go, probably. What I've learned in politics is
undoing things is hard.
Yeah, I've seen more success, at least, in fighting for the workers' benefit and the disability benefit, rather than trying to. I've advocated for basic income, but I haven't got quite. I haven't seen the same success. That's a dollars and cents question in part. Although I'm glad that you mentioned housing, because that is also, when we look at. I was kind of shocked by this. I knew the federal government had gotten out of the game over decades, and this government is back in the game, although again not as much as it should be on the social housing side. We spend about less than half of the OECD average, and I spoke to a counselor in Sault Ste. Marie recently who shared a report with me that obviously it's the right thing to do for all sorts of reasons and the social determinants of health. There's also a massive productivity gain by focusing on housing, ensuring that people have housing, and building that community housing.
Exactly. There's sustainability, and the fact that, if in fact we need 3.5 million new homes in this country, what if we were to actually build homes that were much more energy efficient and would reduce our burden on energy sectors. So, there's a whole lot of things that we can do while we're at it, dealing with making sure that people have adequate housing. We're creating jobs. We're reducing our needs for the resource sector in areas that are going to actually benefit the environment as well.
I want to depart from the book because when you were the health minister and in Parliament, we had many conversations about drug policy, and I recall. I actually think you were quite careful at times in delivering a message that wasn't decriminalization, but you would say things like, "We can't arrest our way out of the problem," and you were saying the same thing without saying a word that scares people because they don't entirely know what it means sometimes. But you have been more forceful even post-politics to say, well, we should support Vancouver and we should support treating substance use as a health issue fully. And you didn't, post-politics, you don't have to manage deal with the Prime Minister's office maybe pushing back and being worried about the politics of it all. I look at it today, though, and I expressed this last week, I worry a great deal about the shifting politics where Toronto has a decriminal request in that's turned down, and you can quibble with the details, but one of the reasons it's turned down is because of politics. You've got Pierre Poilievre, who stands in front of encampments in Vancouver and really weaponizes the struggle of people behind him. He doesn't go in and talk to them. He doesn't say, how do we help? He doesn't say, what do you need? He says, look at these tents behind me, and it's all Justin Trudeau's fault, and it's all drugs, and we need to basically have a war on drugs all over again, from what I can tell. You've lived in politics as health minister where you had to deal with this with safe consumption sites and expanding access to safe consumption sites. Out of politics, you've been more vocal about it. We've got an opioid crisis that's killing far too many people. With what you've learned and what you see now in the health profession, what more do you think we need to do to push back against that fear-based politics, which we see all over again?
We have to do much, much more, because this is now, again, the biggest public health crisis that is facing the country. For a while, it was COVID. Before COVID and after COVID, the biggest public health crisis facing the country is the fact that there are now about 22 people every single day dying of opioid toxicity. And those are real people. And you and I feel very similarly about this. And, I think you don't point to the tents the way Pierre Poilievre does, I point to the people, the real human beings. And I have a chapter in my book where I talk about drug policy. And I start by telling the story of some of my patients. And the reason I have the views that I do around drug policy is because I have known, worked with, cared for, loved people who are dependent on substances. And, you know, we're all familiar with the phrase, you know, but for the grace of God. It could be any one of us. It could be our sister, our children. It often is. You know, people who listen to this podcast, some of them have someone in their life that they love who is dependent on substances. And sometimes those substances are really powerful substances that require them to go out and buy products on the street that are laced with toxic chemicals that will kill them. And this is it's shameful that any politician would not pour energy into trying to solve this problem. If you care about human beings, if you're a politician, you ought to care about human beings. And if you care about human beings, it should be devastating to you to imagine that 22 Canadians die every single day of preventable deaths because we haven't been able to figure out how to put the wraparound supports in place so that those people can have what they need to live a healthy life. And sometimes that means, for a period of time, providing them with other substances that are safer so that they won't need to buy toxic drugs in the street. It means not sending them to jail, but sending them to either treatment or rehab or social services so they'll get the supports they need. Yes, decriminalization is a scary word, and that is one of the reasons why I tended not to use it, because it's so... it seems to send people to places where they make the system black or white, pro or con. And we need a much more comprehensive approach to drug policy. We need to wrap our arms around the people who, because of the horrible things that have happened to them in their lives, have got enough physical or psychological or traumatic pain in their lives that they can't stop using these drugs, and they're dying as a result, and they matter as much as you or I or any person in this audience matters.
You didn't, you know, I mentioned, I think it was a speech at the UN that you had given where you said we can't arrest our way out of the problem. You then had legislation where you rolled back HARPA reforms to make it harder to open and pursue safe consumption sites and harm reduction initiatives. I have seen success on this over the years. At one point, I think I was a bit of a pariah for calling for decriminalization as much as I was. But when I really focused on alternative approaches and ensuring that there was diversion away from policing towards a more health-focused approach, you use different words and you get to a similar place. At the same time, we aren't delivering the scale of a response to meet the scale of the challenge. And so I suppose what I worry about in some ways is whether it is homelessness or whether it is mental health issues or whether it is substance use challenges, when people see them visibly in their community and react in a negative way, if we don't show that a compassionate solution works, then the law and order, tough on crime, fear-mongering politician is going to be more successful than they should be.
I agree with you. So I will just add to that then, since I'm not going to disagree with you, is that, you know, the compassionate approach needs to be a comprehensive, compassionate approach. And that, I think this is where we have erred the most, is that we've taken bits and pieces of what evidence-based drug policy should look like. And, you know, so we've done a teeny experiment with decriminalization here and a little experiment with safe supply over there. And we haven't done the full wraparound look. And there are countries that have reversed what was a really problematic social issue around, drug-related crime, high rates of death, etc. And they've done that by doing comprehensive policies. And Portugal's the classic example, but many other European countries, including Switzerland of all places, have been able to find ways to address this, and they have dealt with the social needs of saying we don't want people living in encampments in the streets. We want people to be able to get access to care.
And when I debate conservatives on this, they'll say, well, we want treatment. And I'll say, yeah, I want
Sure.
treatment too. And I also want all the other things.
Exactly. We want it all.
We can do it together. When you reflect on your time in politics, and I want to get to how you arrived into politics, but when you reflect on your time in politics on the drug policy issue, how many times did you feel like you were banging your head against a wall because we wanted to govern by the polls rather than by that evidence-based drug policy?
I was only Minister of Health for just under 2 years, and I'm really proud of the work that we did during that time. I mean, I still like to remind people that when we formed government in 2015, you needed a prescription to get naloxone. And my very first decision I made as health minister was to say naloxone should be available without prescription across the country. And that's probably the proudest decision I've ever made, because I'm pretty sure it saved thousands of people's lives. And we went from there to, of course, do our work on the Cannabis Act, which was an important piece of work. We did the work to, as you say, reinstitute harm reduction as a platform, make it easier for communities to have supervised consumption sites, of which at the time, again, that we formed government, there were only 2 that were functioning, and they were functioning under an injunction. So we did a lot in a short period of time. There are people who speculate that one of the reasons I got shuffled out of health was because I was making too much progress on drug policy and gotta get her out of the way and give her another job to do. So I don't know whether that's true or not. Someday I might try and find out. But
Okay, so I do want to ask about your time in politics as well. But how did you arrive in politics, though? You're a family doctor for over 25 years. You spent a good deal of that time in Niger and working, as an advocate for saving lives in the AIDS crisis. And how do you go from that world of Doctors Without Borders and on the ground helping people, and there's an immediate help that you're able to provide, to running for office in 2015?
Thanks for asking that. It's actually not a big stretch. So, I think most people, I don't know if there's any other physicians in the crowd, but most people go into medicine because you want to help people improve their lives, save lives, all those kinds of things. And again, such an incredible privilege to be able to be a family doctor and to have those relationships with patients, and one by one people coming into a room and pouring out their most important concerns to you. I loved doing that and being that. But over time, you start to realize that most of the things that make people sick or make them well aren't things that a doctor can fix. And you very quickly start to realize that it is all those big social structures. It's how we've organized ourselves as a society. And I couldn't always help people with those things as a doctor. So you start to do things that might be able to help in a bigger way through mechanisms like medical education or medical research. But it didn't take long to realize that actually health policy and therefore politics was the way to be able to have a bigger impact. And I describe in the book a conversation I had with former Prime Minister Paul Martin, where I kind of made a slightly flippant comment to him about, at one point I was getting his advice on issues around foreign aid, because I was really frustrated with Canada's foreign aid policy. And I made this comment that, some days I think I should just go to Ottawa and try and fix this. And he said, "What?" He said, "Are you going to run for office?" I said, No. I'm a family doctor. I have 4 kids. Like, that would be an absurd thing to do. And he said, "No, if you can go to Ottawa." He said, first of all, you better join the Liberal Party. I guess I wasn't a member at that time. He said, you better get yourself nominated, get elected, hope that the party you join forms government, someday get around a cabinet table. He said, you can get more done in 10 minutes there than in all this advocacy work you're doing on the outside. And the second I heard that, I thought, that's what I want. As you know, politics is a super hard job, but it's also super satisfying, because you actually do get to have an influence on the way we structure our society, and you do get to heal society as opposed to just healing individuals. So I think you and I talked earlier about the quote that I used in the book, which is Rudolf Virchow, who's a 19th century German physician, philosopher, politician. And he talks about the fact that politics is nothing but medicine writ large.
Yeah, I'm not running again, but I'm still firmly of the view that it's the best way to make a difference in the lives of those around us. I will say, when I ran as a Liberal, I think my parents were probably thinking, well, at least he's not running as a Conservative. It could be worse. But when you talk about politics and you talk about your time in politics and the opportunity to make a difference in politics, you must miss politics.
I do. In some ways.
And when we're 5 years, I was rereading some of the not that you want to relive all of this, not that I want to relive all of this, but in early 2019, when the SNC-Lavalin scandal, I think it was in February where the Globe Mail first wrote about it, and there were all sorts of different statements from different people in the media from there contradicting one another. I laughed. I was reliving it because I was reading it. But when the Prime Minister said, well, Jody Wilson-Raybould's presence in cabinet speaks for itself, and then she resigns later that day. There were moments like that were happening. And here you are, you're friends with Jody. Here you are, and you see this as a really important thing to stand up for and to sacrifice a political career for in some ways, although you might not have thought that it was going to lead to that at the time. When you I don't know to what extent you want to relive this, but when you think back to 5 years ago, are you at peace with how it all played out? Do you wish it had gone differently? Do you wish you'd done something differently?
I think for the most part, I would have done well. I know in terms of standing up and saying that I can't be part of this cabinet, I would not do anything differently on that. And I want to emphasize, obviously, I was a friend of Jody Wilson-Raybould, but that wasn't the reason that I wasn't able to maintain solidarity. I thought what the government had done was wrong. They had tried to get the Attorney General to interfere with the largest criminal prosecution in the country, and that's not how the executive branch of government is supposed to run. It is not supposed to interfere with the prosecution, and because they had attempted to do that, I felt it was wrong, and I couldn't deny what had happened. And there's a convention in Canada, as you know, that you have to be in solidarity with the cabinet to stay there, and I wasn't in solidarity, so I felt that I had to step down.
It's sometimes freeing not to have to be in solidarity. I will say, I would have loved to have been in cabinet at different moments and certainly on different files, but I get to look back over 9 years, and I've been able to say the things I wanted to say at the times I wanted to say them, and there is a certain freedom that has been, I would say, very welcome in politics as well.
Yeah. And I mean, as you know, I hoped that I could stay in caucus because I knew that there were people like you who were able to be in disagreement, and that's as it should be. That members of the caucus who are not in the cabinet have the freedom to disagree with government, but unfortunately, the decision
your
was made
expulsion
otherwise.
was another one where I was in the minority on, in that people will see it as the Prime Minister's decision, and ultimately it was a caucus. It truly was a caucus decision, and I was just again disagreeing at the time. But I for whatever that's worth. But I didn't share the same reaction even at the time, in that I was comforted. Obviously, I agreed. I think I spoke at the ethics committee to say the government acted inappropriately and breached a convention called the Shawcross Doctrine in exerting inappropriate pressure. I did at the same time think that the Justice Minister should have exercised the, maybe it's not fair to characterize as due diligence, but she should have consulted more broadly with other cabinet ministers on the economic file around that deferred prosecution agreement specifically. And then in 2006, the one good thing that Harper did, one good thing, they actually put rules in place that separated the prosecution service out of the Justice Department, which then meant that for any Justice Minister to intervene in any proceeding, it would have had to be in the Gazette, it would have been entirely public, there would have been accountability in that way. So I was actually comforted in a few different ways that, yes, there was a there was a inappropriate conduct, but it didn't rise to a level that I felt uncomfortable. Certainly, being in caucus, or my confidence in the government was, I was more shaken when they broke the promise on electoral reform, if I'm being honest. But when you look back at the ultimate finding, ultimately the plea agreement, SNC ultimately pleaded out to $200 and something million in a fine. There were separate consequences for the individuals in charge. We got to a very similar place through a plea deal that we would have got to through a deferred prosecution agreement. Not entirely the same place, but a very, very similar place. I don't know if you followed when that happened. Did you read that and go, all of this fight was for a plea deal that we got anyway? Because that was kind of my reaction. I was like, holy, we lived through all that and we got to kind of the same place. But I don't know if you you had the same, your face suggests you did not have the same reaction as I did.
I would simply say it's true that it got to a good place, and it didn't have to. What happened didn't have to happen.
Yeah,
let's leave it at that.
See, she's still very good at politics. And on that, would you? I mean, in the right circumstances, the way you talk about politics, it sounds like you absolutely would come back to politics. I don't know what those circumstances look like. You miss politics. You've written a book that in some ways demands political action, in many ways demands political action. When are we going to see you provincial, federal, I'm not sure what level, but when are we going to see you back on the ballot?
I am not sure what my next steps are. I am Dean of the Faculty of Health Sciences at Queen's University, Director of the School of Medicine. I love that job. I'm committed to be there for 5 years. I'm just about at the 4-year mark, and I've told them I will not renew for a second term, so I'm at Queen's for another year. I am really, really committed to try to improve healthcare in this country and to try to see the vision that I described in that book become a reality. I don't know where is the best place to do that. Is it federal? Is it provincial? Is it inside politics? Is it in the public service? Is it in a third-party organization? I'm not quite sure what it will look like. I'm scoping out the options at the moment, and I will see what opportunities show up. I want to keep working to make this country stronger and healthier, and I will do whatever role I think it will most effectively achieve that.
Well, had I won the provincial leadership, I would have come knocking on your door. I'm glad I was knocking on your door anyway, so you joined the podcast. But I think it would have been fun to work together again in many ways, because I do think even we can disagree on how things played out in a certain moment in time, but I do think I did not always agree with Jody Wilson-Raybould. I deeply disagreed with her, and we butted heads on many occasions on different files. I was always very impressed with the way you held yourself and the things you were able to deliver as a cabinet minister. And I think one of the most important, for those of us who care about politics and want people to see politics as the most important way to make a difference, competence in politics is an underappreciated value, and you brought that in spades. So I wish you well in whatever that next political life looks like, and I'm very thankful you were able to join us for the podcast. We are going to take audience questions. So before we get there, I just want to say thank you.
It's my pleasure. Thank you.
I have one final question before we leave, and it's a struggle, I think, for sometimes parliamentarians in navigating questions of confidence when you disagree with something, and yet you look across the aisle and you say, but that's the alternative. We can't possibly have that. And so but there are lines you got to draw. And so I don't want to relive the conversation we were having, but instead for voters, they're going to face a choice in the next election where you have an explicitly populist leader, someone who is, as we've talked about, weaponizing certain fears and completely ignoring the evidence around climate and the experts on carbon pricing, and talking in some renewed language around caring about labor when he's got a history of anti-union rhetoric. And I could run down the list, and we don't have the time for it. But there's a real worry that I would have when you see that as an alternative. And right now, if there's an election tomorrow, Pierre Poilievre becomes the Prime Minister of Canada. And yet there are also frustrations that people have, and it's partly frustrations that have accrued over a decade of governing wears on governments. Partly it's people's frustration with the Prime Minister. You, as someone who has experienced those frustrations maybe more viscerally than most, when you look at the next election and you're navigating those choices, how are you navigating that?
Wow, you really did want to give me a nice tough one at the very end.
Yeah, we're closing with this one.
You know what?
I appreciate you coming.
Yeah, thank you. We have to do better at our politics in this country, and we have, I think there are many Canadians who are frustrated because they don't see any options that they feel really good about. And then the worst thing that'll happen out of that is that people become apathetic and they decide not to participate in the democratic process. So I don't know what's going to change between now and when there is the next federal election. But I hope that a few things. I hope that Canadians increasingly speak up about what their expectations are of our elected representatives, how we want them to treat one another, how we want them to comport themselves in public, how we want them to speak to each other, how we want them to speak to journalists who are asking them respectful questions. And if we can try to get those messages out a little bit more loudly, I think that would be helpful. My other big hope is that a much more diverse set of Canadians will step forward and say, I'm going to go and make that place better, and behave in a way that I think that elected officials should behave. We can't abandon the houses of parliament and legislation in this country to people who are there for the wrong reasons, for personal gain, for power, and we need to essentially take back democracy. So that would be my hope.
I'll leave with, that's worth. I'll leave by saying thank you, and it reminds me, you can put all the rules you want in place, but you've got to act how you want the place to be. And thank you, everyone, for joining.
Thank you.